warmly welcome our Honorable Founder Chancellor, Thiru ACS Shanmugam Sir, who has always been supporting and his blessings are always there for us. I welcome our Honorable President. I very warmly welcome our beloved Secretary Sir, Thiru A. Ravikumar Sir, whose support has always been with us. I warmly welcome our Vice Chancellor, Dr. Geeta Lakshmi Ma'am, for her enduring support in all our events. I warmly welcome our Principal, Dr. C.V. Senthilnathan Sir, for this event. And I warmly welcome our guest speakers of the event, Mr. Priyank Jain Sir and Mr. Gnanasekar Sir for this event very warmly. And I welcome all the faculty members who gathered here, and I welcome all the dear students. And it is all for you, so be benefited through the event. Thank you.
Students, let us all rise up for our
Good morning, everybody. Good morning to the dignitaries present on the dais. Very good morning to all of you. I take this opportunity to thank our Honorable Founder Chancellor, our Honorable President Sir, and our Honorable Secretary Sir for giving us this wonderful infrastructure and all the necessary things to conduct such kind of activities like today's workshop and the forthcoming guest lectures. Whatever we plan, we do it accordingly with the help of our management. Without their support, it is not at all possible. And I would like to congratulate our Department of OBG for having invited a well-known person, Dr. Priyank Jain, for this workshop today. And my sincere thanks to Dr. Priyank for accepting this invitation of us to come down over here and to share his wide knowledge among you. After 2 long years of COVID, we were not able to see on the face to face, even for classes or practical classes, theory classes, and a lot of academic activities. We miss a lot. So what we thought was we have to rush up. Almost you are in third year right now, no? Am I correct? So your entire first year, except the initial 3 months, you came to college. So rest of the first year and the whole second year, you are at home. Only now, almost you came to college before 2 months, I suppose. Am I correct? Yes. So we have to catch up what we have lost in the last 2 years. So kindly cooperate with us. So hereafter, every month, one program or the other we will organize, and I expect all of your cooperation to actively participate in all the programs we do organize over here. See, it is not the degree alone you require to excel in your profession. So what are the things you acquire other than in your curriculum? It's more important. So all these things you cannot see in your syllabus. So what today you are going to receive from Dr. Priyank Jain and Dr. Gnanasekar, so it is not there in your syllabus or it is not there in your textbooks. So but it will be very useful when you go out and when you practice your profession, either in India or abroad, wherever you go. So that's what we were talking in my room. Dr. Priyank said, so there is a dearth of physiotherapists in the field of oncology. So there are a number of people are there in orthopedics, neurology, pediatrics, OG, but there is only few people are there in onco rehabilitation. So and only few universities they offer PG program in oncology, in physiotherapy. So we had a discussion in the morning, like we have a plan of starting an MPT program exclusively in onco rehabilitation. But what sir suggested is, instead of having it in MPT level, why can't you have it in the UG level itself? So just like your PT orthopedics or PT neuro subject, we can have one more subject, like physiotherapy in onco rehabilitation. So we were discussing about the syllabus content part of all those things. Sir is very kind enough. He said, like he assured me that he will share the syllabus where they are following in Doha. So shortly, maybe your juniors might have that subject in their curriculum. Okay, good. I could see a lot of young minds and faces fresh, bright, vibrant. So my sincere piece of advice is be alert, gain the knowledge, what is sir is going to share with you, and put it in practice. And a piece of advice to the organizers, the function was a little bit clumsy, so we have to, Deepthi, no, it's about you only. See, the function is a bit clumsy. I could see a lot of confusions there. So it was not planned properly. So whatever we do, we have to plan accordingly, and we have to execute it. So this should not happen again, because we are streaming it in live in YouTube channel. So everything, any mistake we do, it's a mistake. We cannot rectify it. So be careful in future programs. But as a whole, it's good. Keep the spirit going, do hard work. Thank you very much. Thank you for the opportunity, and listen well. This is the most important workshop where you cannot gain such kind of knowledge. Clear? Thank you.
Thank you, sir. Thank you for that. So you can all be seated here. So it's time to welcome our Priyank Jain sir. So this is about his introduction. So Priyank Jain sir is an Onco-Physiotherapist, Lymphedema therapist in National Center for Cancer and Research Center, Doha, Qatar. So sir has completed his UG from BIMR College of Life Sciences in Jivaji University. And sir has received a Young Achiever Award from AIIMS New Delhi in 2015. And sir is currently working in Hamad Medical Corporation, Doha, Qatar since March 2018 as a physiotherapist and a lymphedema therapist. And about his certification, sir is a certified yoga instructor, since 2019, tobacco cessation expert from Tata Memorial Hospital, Mumbai, and cancer physiotherapy specialty, breast cancer rehabilitation specialist in Tata Memorial Hospital, Mumbai again, and certified aerobic trainer from IIFT 2011, and certified athlete care and rehabilitation from Gwalior. And sir has conducted many workshops around the world. And what more we can ask for? The most eminent speaker of the day. So welcome you, sir. The stage is all yours, sir.
Special thanks for Sensor Aban sir to give this opportunity to deliver my knowledge in budding physiotherapist. As sir said, this is the new field in physiotherapy, but it is a booming field. Still, we are very less in onco-rehabilitation. Myself, Priyank Jain, I am working as a Onco-Physiotherapist in Doha, as Madam said. So I will not take your time. I will start my lecture as we are running late. So we will start with basic anatomy. I will revise your first year and second year. So be interactive with me, because I will never take any lecture or workshop without interaction. I can come between you, I can ask anything. Whatever you know, just say. This is my disclosure. Next. Okay, so in this slide there is some developmental formation of lymphatic system. It is saying that it is starting in the end of the 5th week of gestational periosteum and joint structure, as I told. And there is some connection between superficial and deep system, which is known as perforating vessels. Like how superficial system is draining the lymph towards the deep system, there are some vessels which is known as perforating vessels. Okay, next. As like a blood circulatory system, I told that this is a single, there is one difference, this is a one-way system, there is no central pump like a heart, but it is almost similar in terms of vessels. So in lymphatic system, there are some vessels. Depending on the size, there are different names, starting from lymphatic capillaries, which is also known as the initial lymph capillaries, which is the beginning of the lymphatic system. This is starting from the interstitial, like a capillaries, then pre-collectors, then lymph collectors, lymphatic trunks, lymphatic ducts. No need to confuse, because these are the almost same structure, depending on the size and depending on the some difference. These all are the vessels in the lymphatic system. Then there are lymphatic organ, which is situated in our body, mostly thymus, lymph nodes, spleen, tonsils, Peyer's patches, and our bone marrow. These are the lymphatic organ which is helping to produce the lymph, or the main cell, which is T lymphocyte or B lymphocyte. You know about T and B lymphocytes? Anyone? What is the function of T and B lymphocytes? Boys and girls. What is the function of T and B lymphocytes? Madam? Good. So, lymph vessels, capillaries, pre-collectors, collectors, trunk, and duct. Lymphatic organs situated all over the body, which is the first line of defense of our body, because they are producing lymphocyte, which is responsible for the immunity. So spleen, thymus, Peyer's patches, which is situated in the colon, and lymph nodes and lymphatic cells. Next. So like a blood capillary, lymphatic capillary is almost same to the blood capillaries. This is blinded end, because it is starting from the interstitial fluid. There is no connection with the veins or arteries. is directly started from the interstitial fluid. It's the beginning of lymphatic system with a small structural and functional unit of lymphatic system. Initial lymph vessels or lymphatic capillaries. Single layer. This is the cross section of one lymph capillary. It is made up of single layer of endothelial cells which is overlapping with each other. And this function is governed by some filament which is attached to the nearby cells, which is known as anchoring filament. When I will explain the function of lymph capillaries, at that time you will know that what is the function of anchoring filaments. It is more permeable than the blood capillaries because previously I told the substance or the molecule which is not able to transfer by the blood capillaries is coming from the lymph capillaries. Big protein molecules, long chain fatty acids is coming from the lymph capillaries. So the force between two endothelial cells is much larger than the capillaries in the blood vessels. Got it? Yes? Yes? Or no? Next. No. So this is arteriole. Venule. They have connection by the capillaries. See, arteriole, these are the small branches known as capillaries, blood capillaries. In between these are the cells, and in between the cells, this is the interstitial space between the cells. And these green is the lymphatic capillaries, which don't have any connection with the arteries and veins. So that's why it is blind end. It is starting from the interstitium, nearby cells. These are the filament which is anchoring the endothelial cells, and the substance which is present inside this capillary is known as lymph. Next. So I told the lymphatic capillaries is the structural and functional unit of lymphatic system. So in lymph capillaries there is some wall. So the structure between the two walls, these are the endothelial cells, and these are the lymph capillary wall which is guarding the direction of lymph. So the distance or the structure between the two walls is known as lymphangium. Got it? The structure between the two walls in the capillaries is known as lymphangium. The lymphangium is the functional unit of this system. Once I will proceed, then you will know about the lymphangiomotoricity, how lymphatic capillaries is working and which force is helping to work. Got it? So the functional unit of lymphatic system is the lymphangium. Between proximal and distal pair or walls. Got it? This is surrounded by the smooth muscles. Next. Once the lymphatic capillaries is collecting the lymph from the interstitial fluid, they are forming the big tubes, which is known as lymphatic vessels. These are the different types: pre-collectors, collectors. The pre-collectors is the tube between the collectors and the capillaries. The pre-collector is draining the lymph from the capillaries to the collectors. Lymphatic vessels is almost similar to the blood vessels. There is 3-layer wall, but thinner than the veins. It is not that much big. It is smaller than the vein. Can anyone tell how many layers in our blood vessels, artery and veins? Same 3 layers. The name of 3 layers. The name of 3 layer which is present in blood vessels, arteries or vein. I will start like 2 make up. tunica. Who's the topper of class? Tunica. Next. Stand and tell. Good. So same layer is present in the lymph vessel. Tunica externa, which is also known as tunica adventitia. Tunica media is made up of muscle layer, and tunica interna is made up of endothelial cells. Yes? Lymph capillaries have more walls as compared to the veins. Okay. When lymphatic vessels is running throughout the body, there are some nodes present all over the body, which is known as lymph nodes. Yes? So I will explain about the structure. So it is written that interposed by lymph nodes at different intervals. So all over the body we have like 600 to 700 lymph nodes. During cancer surgery, surgeon is removing the lymph nodes to stop the spread of cancer. Yes? If cancer cells is present in the lymph node, means cancer is metastasis. Yes? So they are removing the lymph nodes. So they are removing the part of the lymphatic system. So if there is less part in the lymphatic system, there is chance of something wrong. Yes? If it is compensated, it's okay. If it is not compensated, then there is some disturbance in the system. Yes, previously it says that approx 10 to 20% of fluid is coming from the lymphatic system, 70 to 80% fluid is coming by the venous system. But nowadays, there are more research which is saying like more than 60 to 70% of fluid is coming by the lymphatic system, not the venous system. Yes? So in your, maybe in future you will see the person has fracture, multiple trauma around the ankle or knee. The surgeon did the fixation. After fixation, there is some time period. They started physiotherapy or rehabilitation. You will get some range and strengthen the muscles. But after 3, 4 or 5 or 6 months, there is still swelling present in the knee or the ankle, which is not managed by the elevation, which is also not managed by the cold compression, which is also not managed by the crepe bandage. It's coming again and again and again, it becomes hard. It's not a normal edema. So in the orthopedic also there is a lymphedema, because the lymphatic system due to trauma is disturbed. Even in the burn, there is no edema later on. The lymphedema is not start immediately, it takes time. And lymphedema is not a symptoms like edema. Lymphedema is a disease. Yes? So you will use this knowledge in orthopedic also. If you will see patient with chronic swelling after fracture, maybe 6, 7 or 8 months, or maybe chronic venous insufficiency. When there is varicose vein, there is cluster of the vein in the leg. Initially they start swelling, but it comes and go, comes and go, comes and go. Later on, the swelling is stuck. Because at that time, the present lymphatic system is not able to transport the lymph node. It is stuck. Yes? So you will use this knowledge even in the chronic venous insufficiency patients. You will use this knowledge to treat obese onco-rehabilitation. You will use this knowledge to treat post-traumatic multiple fracture patients. Yes? So, yes, next. So there are different threads. So lymph capillaries, later on pre-collectors, more than bigger as collectors, then trunk. So there are different tubes is present in the different area. Right and left jugular trunk is present here. Okay? Right and left subclavian trunk present here. they will connect and they will drain in the lymphatic system at this junction in the superior vena cava. Yes. Right and left bronchomediastinal, the trunk which is taking lymph drainage from the chest. Right and left lumbar trunk, the trunk which is taking the drainage from the abdomen and the lower area, and intestinal trunk. Okay, so capillaries, collectors, and trunk. Next. So jugular trunk, subclavian, bronchomediastinal, lumbar, and here gastrointestinal trunk. They will collect the lymph depending on the body part. After that, all trunk will come to a larger lymphatic vessels known as lymphatic ducts. In our body, there is only two lymphatic ducts. One is thoracic duct, one is right lymphatic duct. The thoracic duct is also known as the left lymphatic duct. So this is the right side of the body, which is drained by the right lymphatic duct. Right side of the head, neck and face, right shoulder, right chest, right upper lip. It's full drained by the right lymphatic duct. In over 24 hours, it is draining about 300 to 400 ml of lymph. Okay? The main lymphatic duct is the thoracic duct or left lymphatic duct, which is draining the area left head and neck and face, shoulder, left upper arm, left chest, whole abdomen, both lower limb. It is draining approx 3 to 4 liter of lymph in a day. Okay, next. So these are the lymphatic organ, bone marrow. So starting with the adenoids, most of the young, like kids, they are suffering from some breathing difficulty in the 3, 4 or 5 years of age, and due to some infection in the adenoids, so either they have to wait for further more years, it will settle down, or they need to do some surgery to remove the adenoids. So this is the adenoids. Then tonsil is known as policeman of buccal cavity. When there is some infection in our throat, the tonsil is swollen. Sometimes we need to go for tonsillectomy. This is also a lymphatic organ. Then come to the down, there is thymus. These are the lymph vessels, lymph nodes present all over the body. These are the paired spaces when you study like ascending colon, transverse colon, descending colon. There is some pocket-like structure attached to the colon. It's known as paired spaces. They are responsible for the absorption of fat molecules and fat-soluble vitamin. If you don't have a good lymphatic system, you are prone to develop the vitamin which is having fat-soluble. What are the vitamins which are having fat-soluble vitamin? Name. Fat-soluble vitamin. Huh? A, D, headache. Huh? Okay, so the paired spaces is responsible for the absorption of fat molecules from the colon as well as the fat-soluble vitamin. Then appendix is also lymphatic organ, and some part of the bone marrow is helping to prepare some blood cells, also lymphocytes. So lymph nodes, it's like a kidney. It's small, very small. It's a bean-shaped structure. It is the outer cortex, inner medulla, capsular cell producing. There are two, one is input, one is output. The two which is going inside is known as afferent. Yes, the two which comes out the lymph node is efferent. So afferent is larger than the efferent. The function of lymph node is concentration of the lymph, providing some immune system for the body. So outer cortex, inner medulla, it's having a fibroblast cells, macrophage cells, dendrite cells, of course T and B lymphocytes. In all over the body, there is 600 to 700 lymph nodes, and most of the lymph node is present in our head and neck area. Approx 300 to 350 lymph nodes is present in only this area. So when you will go further and you will choose onco rehabilitation and you will go see the oral cancer cases, at that time you will know how important we are. Because this is a very small area where surgeons need to choose what they need to remove, what they no need to remove, because every vital structure which is going towards the brain, carotid artery, jugular vein, condensed area, many muscles. So this is a very special area in onco rehabilitation because it having a 300 to 400 lymph nodes. Remaining is all over the body. Till now, any question? Till now, any question? Understand well, huh? Really? Okay. What is the functional unit of lymphatic system? What is the functional unit of lymphatic system? I told you in the beginning. Huh? It should be interactive. Otherwise, I will not take any practical if you don't understand the lymphatic system. Lymphatic. Sit. Thank you. Thank you. So lymphatic system is a two-way system or one-way system? Huh? Heart is present in lymphatic system or blood circulatory system? Huh? Heart is a part of blood circulatory system or lymphatic system?
Blood circulatory system.
There is any heart in lymphatic system? Then how lymph flow is going? How lymph is flowing? There is no heart. By the grace of God? So I will explain first this, then I will come to the water sense. Flow of lymph. So just read this carefully. Lymph flows under forces similar to those that governs venous return, except no pump. So what are the forces apart from heart is helping the venous return? What are the forces apart from heart pumping is helping to return the blood from the veins? Very good. Muscular pump. Yes. Continuous smooth muscle activity, our walking, our some active movements of the day is helping to return our venous flow. It is also helping our lymphatic system. Second is the breathing. Yes. Breathing is also helping to create a negative pressure and it is also helping to flow of the lymph. Lymph flow at low pressure and slower speed than the venous blood because the vessels is smaller than the veins. moved along by the rhythmic contraction of the lymphatic vessels by the help of the smooth muscle which is present in the tunica media of lymphatic vessels. Flow aided by the skeletal muscle pump, as he said. Arterial pulsation rhythmically through lymphatic vessels nearby the arteries and veins. There is thoracic pump breathing, and I told you there is wall present in the lymphatics. The distance between or the structure between two walls is known as lymphangium. What? Lymphangium. So wall is also guarding the lymph flow. Once lymph pass to one lymphangium to the other lymphangium, it will not come back. It hold. Yes? See, once lymph pass from here to here, it will not come back. It will go up, up, up. Because these valves will open in this way. It will not open here. Yes? So breathing, arterial pulsation, muscular activity, smooth muscle activity, and guarding of the wall is helping to flow the lymph. Yes? There are some things which will increase the lymphatic flow. Temperature. If the nearby temperature increase, there is more activity in the lymphatic channels. Yes? So there is indirectly we are increasing the lymphatic movements by the manual lymphatic drainage, which you will learn later on. We are increasing the lymphangion activity by doing some special guarded manual lymphatic drainage. Okay? What is blood? Huh? Connected tissue. Which type of connected tissue? Like a muscle? Huh? Yes? Fluid. What is the composition of blood? Huh? Plasma and? Huh? Plasma and platelets. So blood cells and plasma is a composition of blood. So blood minus cells is equal to plasma, which is present inside the blood capillaries. Yes. There is filtration is going on in the interstitial fluid, yes, by the capillaries and between the intestines. The things present in the interstitium is known as interstitial fluid. And lymph capillaries is forming the lymph from the interstitial fluid. So lymph is almost similar to the interstitial fluid. But the main difference is the protein fat. Yes. So what is lymph? Tissue fluid, mostly interstitial fluid. It enters in the lymphatic channels. What is the starting vessel of the lymphatic system? Which is starting like green projection. Huh? Lymph capillaries. So lymph is protein, main component. Water, cellular components and fat in the intestinal fluid. The substance which is not absorbed by the blood capillaries is absorbed by the lymph. So that's why when you read the definition of lymphedema, it is protein rich fluid. That's why it is harder. That's why it's a thick edema. So lymph is more in protein, water, cellular component like cell debris, some cells, T lymphocyte, B lymphocyte, macrophages, and fat. Fat is coming from the abdominals, from the colons. There is paired patches is present. Yes? So once the fluid is inside the lymphatic capillaries is known as lymphatic load or lymph. Okay? So function of lymphatic system, as I told you, it is maintaining the fluid balance. The fluid which is not able to come out from the blood vessels is coming from the lymphatics. So lymph interstitium space, lymph capillaries, collectors, trunk, duct and blood circulatory system. Duct, I told you this structure. So here they are draining here, the junction of the internal jugular vein and subclavian vein. The right lymphatic duct is draining between this. The junction between internal jugular vein and left subclavian vein. The left lymphatic duct or thoracic duct is draining lymph here. So ultimately it's coming in the blood circulatory system. Got it? So all over the body here. So it is helping in the fluid balance. It provides immunity because they have a more T lymphocyte, B lymphocyte and macrophages, and also it helps to absorb the fat soluble vitamin and fat. So three main functions: fluid balance, immunity and fat absorption. Water cell. When I will start MLD, manual lymphatic drainage, or when you will learn about the bandaging, there are some imaginary lines present in our lymphatic system. The superficial lymphatic system is making the plexus all over the body. Okay, so there are some imaginary line which is dividing our body in the different quadrants, different parts. So these imaginary line is helping us to drain the lymph from one side to another side or up to the down, or when we need to draw the pattern of the lymph if there is removal of lymph nodes. So for this we need to know about the connections of these lymphatics all over the body. So these linear imaginary line which have very less connections is known as water cells. Okay, which is present superficially in our body. So there are mainly three water cells. First is dividing the body right and left half. What is the name of this suture? What is the name of this suture? Suture. This suture. Sagittal. Huh? So this is sagittal water set or median water set, which is dividing the lymphatic plexus into right and left half. It is anterior, it is posterior. Okay? So if there is any lymph node resection in the axilla, so we need to drain this lymph in the unaffected part. So we will follow or we will cross this median sagittal set. Okay? So median sagittal water set, anterior and posterior. There is two horizontal. One is upper, one is lower. Okay? So this is running towards the clavicle, which is separating the neck head from the thorax. Okay? And this is lower horizontal water set, which is separating the thorax from the abdomen. The lower water set is running towards the umbilical line. Okay? So sagittal water set, upper horizontal, lower horizontal. Got it? Posterior, anterior. Got it? So this area between upper horizontal water set, anterior, lower, and it's come here back is known as right upper quadrant. What? Right upper quadrant. The water set is dividing our whole trunk in 4 quadrants. It will help you to drain the lymph when you will see any breast cancer related lymphedema, when you will see any urogenital case of lymphedema, there is removal of lymph node. If you don't know about the quadrant, you will not be able to drain. So this is the right upper, left upper, right lower, left. So right upper quadrant, all lymphatic ducts is draining in the right axillary lymph node. Left is draining in the left axillary lymph node. Right lower quadrant is draining in the right inguinal lymph node. Left lower quadrant is draining in the left inguinal lymph node. Okay, so these are the territories of the lymphatic system. Right is going right axilla, left is going left axilla, right lower is going right inguinal, left lower is going left inguinal. Got it? So these are the quadrants divided by the water sets. Sagittal, part anterior and posterior, upper horizontal, lower horizontal. And there is one special quadrant which is known as gluteal quadrant, which is present here. It is not mentioned here, but that the gluteal water set is not that much important. You just need to focus on these water set 3. Sagittal, upper horizontal and lower horizontal. As we are focusing on the breast cancer rehabilitation, I will just give a little brief about the right or upper limb lymphatic system. Okay. So this is full upper limb lymphatic system. This is in the arm, elbow and forearm, and this is forearm and wrist. So when we will do the demonstration of MLD, these are the direction we need to follow. Because full upper arm is draining in the respective axillary lymph nodes. Right upper arm is draining in the right axillary lymph node. Left is draining left. Got it? So these are the radial. The lymphatics which is present on the radial side is known as radial bundle. The lymphatics present on the ulnar side is known as ulnar bundle. Mesocenar, that eminence on the palm. Okay, so here ulnar, here radius, ulnar, this is ascending, this is descending. Some lymphatics is present in the radial forearm bundle, ulnar forearm bundle, and medium forearm. These all lymphatics is running longitudinally. You can see here. Yes. So when we do the practice of lymphedema, so we need to drain the lymph from here to here. Yes. So our hand position will be always perpendicular to the lymphatics, and we will do drain like this from distal to proximal. Okay. So hand bundles, radial, ulnar, mesocenar, descending. This is forearm bundle, radial, ulnar, and medial. Here some lymph nodes is present at the antecubital fossa, and these are the lymphatic vessels in the arm. Inner side is known as medial, outer side is known as lateral. Lateral and medial. Got it? So these all lymphatics is draining in the axillary lymph node. So if there is removal of axillary lymph node, which is common in breast cancer patients, so you will see axillary lymph node dissection. Yes, common. So we need to drain this lymph not here, here, here. So you will learn how to reroute the lymph. Got it? So This is the lymphatics of upper limb. Any question? Any question? Any question? Otherwise, I will ask. No? Done? Brother, tell me the water sets. Water sets. How many water sets present? How many? Huh? 3. Name. No. How many water sets? 3. 4. Name. The quadrant, which is divided by the water sets. Water sets. 3. Sagittal. Upper horizontal. Very. Name. Now water set is dividing the body into the quadrant. Yes? And according to the quadrant, you will drain the lymph. Okay? So this quadrant is known as right upper, which is draining the lymph from this full area, even the back to the right axillary lymph node. Yes? Then this is left upper quadrant, draining the lymph into the left axillary. This is the right lower quadrant, draining the full lymph in the right inguinal lymph. This is the left lower quadrant, draining the lymph into the left inguinal. So, when you will see the lymph plexus in this, so you will see this lymph vessels. There are some connection between the lymph vessels, as like a venous system or arterial system, is known as anastomosis. You know? So there is lymphatic anastomosis also present between inside the quadrant. Okay? So like if you will see here, so there are many anastomosis present in right quadrant, many anastomosis present in the left quadrant, many anastomosis is present the right lower and right left. But in between, inside the quadrant, okay? But there are some anastomosis is present between the quadrant. Yes? Which is transferring the water, but very few, which is helping a lymphedema therapist or physiotherapist to drain the lymph to the opposite side. Okay? So some anastomosis, some junction, some connection is present between the right and left here. Some connection is present between here and here. Okay? But very few. Normally anastomosis is present inside the quadrant, but there are some anastomosis is present between the quadrant along the water side. Okay? When I will do the demonstration, at that time I will explain you. So there are some anastomosis between right and left axillary lymph node. There are some anastomosis between right and left inguinal lymph node. So if there are some anastomosis between right upper quadrant and right lower quadrant, There is some anastomosis between left upper quadrant and left lower quadrant along the water side. Yes? What is the functional unit of lymphatic system? Say loudly. What is the main lymphatic duct in our body, right or left? Eh? What is the main lymphatic duct in our body, right or left? Eh? Right or left? So right is draining about 300 to 400 ml lymph in a day. And what about left? How many lymph nodes is present in our body? 600 to 700. Out of 600 and 700, mostly present in which area? Very good. Thank you.
So we will rush up and we will fast with what will happen if the lymphatic system will be damaged, right? So we all know edema, right? Any injury, any post-injury, we will develop edema. So what will be the difference between edema and lymphedema? So what is an edema? Sorry? Accumulation of water swelling. Water swelling. Swelling management. What is inflammation? See, we have all different zones. Edema, swelling, inflammation, lymphedema, right? Okay. In the break, like lunch break, சாப்பிட்டு முடிச்சிட்டு இது மூணுத்துக்கு டிஃபரன்ஸ் சொல்லுவீங்க சரிங்களா? I will jump into lymphedema, but you have to tell me what is the difference between swelling, edema and inflammation. The person who is telling correctly will be awarded. Okay? Yeah. So, what is lymphedema? So, lymphedema is nothing but a chronic lymphatic disease characterized by abnormal accumulation of lymph in the interstitium. So, if the interstitial fluid is not getting into the lymphatic vessels or lymphatic capillaries, if the lymphatic capillaries are unable to pick up the interstitial fluid, so the existing fluid that remains in the tissue, they will long-standing accumulation of those fluid will be termed as lymphedema. Lymphedema is technically injury to the lymphatic system because of that the fluid is not entering, right? Or any malarrangement or any malformation for the lymphatic system. Because of the injury of the lymphatic system, if the interstitial fluid is retaining in the interstitial space itself, we will call it as lymphedema, right? So what is breast cancer related lymphedema? So by this time, Priyank has already explained you how the lymphatic channels are associated, right? What are the requirements and what are the lymphatic nodes that will take the lymph from the interstitium towards the heart, right? So while doing a breast cancer surgery or while doing a radiation therapy for breast cancer, usually the first and foremost part that will get affected will be the lymph nodes. Okay, like நமக்கு ஜுரம் வரும் இல்லைங்களா? ஜுரம் வரும், சளி பிடிக்கும், டான்சில்ஸ் வரும். அப்ப நமக்கு இந்த இடத்துல நெருக்கடி சொல்லுவோம் இல்லைங்களா? So inflammation of lymph nodes that will happen on the same thing in the breast tissue, right? So when we develop an infection or any foreign foreign injury, so the first line of defense will be the lymphatic system, right? One of the functions of the lymphatic system is the defense mechanism, right? So any injury to a part will result in activation of the lymph nodes. Okay, so அதேதான். So breast injury இருக்கு, breast ஒரு கார்சினோமா இருக்கு அப்படின்னா அது எங்க கொண்டு போய் கடைசியா சேர்க்கும் அப்படின்னா அந்த மேக்ரோபேஜஸ்ல எங்க கொண்டு போய் கடைசியா சேர்க்கும்னா lymph nodes தான் drain பண்ணும் சரிங்களா? So already he has explained what are the lymph nodes that is present in the body and what are the lymph nodes that will possibly include when we do some surgeries for breast cancer, right? So the main nodes that will be included for surgery in breast cancer is axillary lymph nodes. Okay, so during surgery, like either it's a mastectomy, simple mastectomy, lumpectomy, or an MRM, or total mastectomy, anywhere we will go for two types of lymph dissections. One is sentinel lymph node dissection and one is axillary lymph node dissection. So sentinel lymph node dissection enna பண்ணுவோம்னா we will inject a trace amount. சரிங்களா? So we will inject a tracing dye and we will see which are all the nodes that are infected. சரிங்களா? So இப்போ ஒரு குவாட்ரண்ட்ல வந்து டியூமர் இருக்குன்னா அந்த டியூமர் கிட்ட நம்ம டை இன்ஜெக்ட் பண்ணுவோம். சரிங்களா? அதை வந்து பிக் பண்ணிட்டு எந்த லிம்ப் நோட்ஸ்க்கு ட்ரெயின் பண்ணுதுன்னு பார்த்துட்டு அந்த லிம்ப் நோட்ஸை மட்டும் டிசெக்ட் பண்ணுவோம். ரைட்? தட் இஸ் சென்டினல் லிம்ப் நோட் பயாப்சி. ஆனா என்ன இஷ்யூனா the sentinel lymph node biopsy will work only in the early stages of cancer, right? When the cancer is at the stage 1. Okay. But in Indian scenario, mostly the people will go for advanced stages. They will neglect. So the patients coming to the surgery or to the onco-physician for the management of breast cancer are at the not at the earlier stage. They are coming at a later stage. So there is no chances for us to do the sentinel lymph node biopsy. So we are forced to do the axillary dissection. So axillary dissection or axillary clearance, we will be clearing all the axillary nodes. So henceforth the continuation of the lymph vessels will be interrupted. Right? Enna? Okay. So enna? Lymphatic channel is a continuous process. Or continuous channel. சரிங்களா? So left side of the breast affected ஆயிடும். இங்க இருந்து lymph எல்லாமே collect ஆகி axillary node போகுது. Axillary node வந்து next adjacent parts of the trunk transfer. What we are doing is we are mechanically disturbing the part. Lymph nodes, axillary lymph nodes, we are resecting and we are leaving the other part of the lymphatic channels alone. Lymphatic channel, it is a continuous channel, right? இங்கேருந்து வர்றத இங்க lymph nodes வழியா போயிட்டு அங்கேருந்து ட்ரங்குக்கு போகணும். நம்ம என்ன பண்ணுவோம்? நடுவுல இருக்கிற lymphatic nodes எல்லாத்தையுமே எடுத்து வரும். So we are dissecting everything. So this will be left out. There is no continuation in the system, right? What will happen? Because of the non-continuation, the lymph will be retained in the arm itself, right? So this is happening in the surgeries of breast cancer related lymphedema. So when these types of surgeries are undergoing, like axillary lymph node dissection, this will happen. So this tends to form breast cancer related lymphedema, right? So breast cancer related lymphedema is a prevalent complication secondary to cancer treatment, which significantly impacts the physical and psychological health of breast cancer survivors. Every breast cancer patient is at a lifetime risk of BCRL, and the risk goes on increasing as the follow-up period increases. Right? Like if you take like 10 years back, the prevalence of cancer is less, and the post-morbidity is less. If அப்படியே reverse sides, prevalence of cancer is very high, right? Like if you screen 100 members, like you can be able to pick up any one person with cancer. So the scenario has been changed. But because of the advancements in the surgical treatments in the medical management, the lifespan of the survivors have been drastically improved. Like 5 years ago, இப்போ 20 வருஷம் வரைக்கும் இருக்காங்க. Post surgery or post management. So as the survivorship increases, the chances of lymphedema and the need for the quality of life that the patients need is getting increased. So that is the role what we are going to play, right? Okay. So lymphedema cannot be cured, but it can be managed. They cannot be cured because there is a mechanical disadvantage. As I told, we have an incontinuation. The continuation has been stopped. Okay. So we cannot repair it with other vessels. Like what we do for venous issues, venous anastomosis. So like that, we are unable to use lymphatic anastomosis at all. So the lymphatic anastomosis or the lymph node transfers or venous anastomosis surgeries, they have a very less success rate. So like 7% success rate. That too in a very highly costly surgeries. They are very microvascular surgeries. Comparing to vascular surgeries, they are even more minute surgeries. So the price of the surgeries are very high and the success rate is very less. people are not opting, and what we tell, don't go for surgery, because post-surgery failure, it will drastically increase the chances of lymphedema and it will worsen the chances of lymphedema. Right. So, like surgical treatments like ALND, SLND, like axillary lymph node dissection and sentinel lymph node biopsy. So, BCRL can occur in finger, hand, arm, and trunk. So, watershed, you explain quadrants of watershed explain. So, you have been explained what are the quadrants of watershed. So, it is not only the arm that is going to affect it, it is the entire trunk, right? Both backside and the front side, anterior and posterior part of the trunk will be affected because of lymphedema, because all the lymphatic channels are running from here to the axillary lymph node, right? Like, due to awareness and better diagnostic criteria, early stage or subclinical lymphedema is diagnosed, which in turn help in better treatment outcome and prevents complications. So, like nowadays, because of the advancements, we can able to pick up the lymphedema earlier stage, right? So we will measure and we will say like it is greater than 2 centimeter. So we say it is a the patient is starting to develop lymphedema, and we will start jump into management phase. Like in olden periods, we have no clue on lymphedema how we are going to manage. So it is left out, and the patient will come to us in stage 3 of lymphedema, where the fibrosis has been set up in the skin, and the patients will be suffering a lot. And managing the fibrosis skin, managing the fibrous lymphedema with all skin changes, it is very hard for us to manage also, right? So, how does lymphedema develop? So, during breast cancer surgery, the surgeon cuts through the collectors to remove the lymph nodes and the malignant tissue. Some collectors remain intact but get overworked. Development of mural or valvular insufficiency results in lymphedema. As I told, during surgery, the doctors will cut the lymphatic nodes. Because of the lymphatic nodes has been cut, there will be insufficiency caused because of the transport capacity. Right? Remain till the end of our life, the lymphatic production will be on. Like till the circulation is on, there will be left out of the fluids. So left out of the fluids will be collected by the lymphatic capillaries. Right? Like if the atoms of the size of the molecules like 4 carbon atom. Okay. So anything above 4 carbon atom cannot be absorbed in the venule end of the capillaries, right? So heart, artery, arterioles, capillaries, venules, vein, again heart. Okay. The capillaries இருக்குங்களா, capillaries ஓட venule இருக்கு. அங்கதான் வந்து நம்ம சொல்லுவோம் இல்லையா, good blood, bad blood சொல்லுவோம் இல்லையா. Bad blood will be collected when there is more than 4 carbon atom. அதுக்கு மேல இருக்க size of the particles cannot be penetrated through the capillary end of the venules, so it will be left out. Okay, those particles will be carried out via the lymphatic system. Lymphatic capillaries have the larger holes, so that they can easily absorb the larger particles, right? So அந்த மாதிரி particles absorb பண்ணிட்டு எடுத்துட்டு போற workல we have a mechanical disadvantage because of the we are removing the lymphatic nodes. சரிங்களா? Because we are removing lymphatic nodes, there is a mechanical insufficiency, but the transport capacity is also diminished. For mechanical insufficiency or transport capacity. Transport capacity is nothing but the movement of lymph in the lymphatic system. The ability of the lymphatic system to transport the lymph inside the lymph vessels, right? And the capacity வந்து reduce ஆகுது. அது ஏன் reduce ஆகுது? ஏன்னா nodes கிடையாது, continuous channel கிடையாது, அதனால it is getting reduced, right? So then the patient will develop lymphatic. Understood? இது வரைக்கும் clear இருக்கா? Any doubts? Any doubts? So doubts இருந்தா அப்படியே அப்பா கேட்கு, சரியா? So you can ask on and off. So already he has explained the lymphatic drainage of this. Like 75% of the lymphatic drainage of the mammary gland is in the axillary lymph node, and 25% of the lymphatic drainage in the parasternal lymph nodes. Right? Axillary lymph node also drain the upper quadrants and the extremity. So already he has explained what are the watersheds and what are the quadrants, and axillary lymph node also drains the upper quadrant and the extremities. Like parasternal lymph nodes are deep and are not removed in the breast cancer surgeries. So during breast cancer surgery, parasternal lymph nodes are not removed. Okay, but during the radiation therapy treatment, the parasternal lymph nodes will be affected, will be fibrosed, henceforth they will become inactive. So stimulating a parasternal lymph node is also necessary, right? The next. So perforating collectors are located in the paravertebral, parasternal, intercostal areas which perforate the fascia, thus connect the superficial and deep lymphatic system. So this is also told by you. Okay. So skin, fascia, deep fascia, muscle, bone, etc. Skin, superficial lymphatic channels, deep lymphatic channels. ரெண்டுத்துக்கு நடுவுல perforating channels இருக்கு. சரிங்களா? So these perforators will transport the lymph from the superficial part to the deep part. Understood? Yeah. And the lymphedema that we will be treating will be on the superficial part alone. We will not be treating the lymphedema on the deep part. And until now, there is no cases that has been diagnosed as the patient is having a deeper lymphatic system failure. So the patient is not having a deep lymphatic system lymphedema at the patient's curve. So we are not yet come across those kind of stuff. That because the deeper lymphatic system are larger vessels, right? They have a proper anastomosis with the venous system. So the flow will be easy and it will move. Second thing, the edema that we are treating is above the skin and below the fascia. Above the skin, below the fascia. That so அப்படி இருக்கிறதுனால தான் the skin can accommodate more and more edema. The skin can expand to its maximum and it can accommodate more. சரிங்களா? So we are treating only the superficial lymphatics and the superficial lymphatic edema. Then, so we already explained this. So what is the incidence of lymphedema? So worldwide incidence of lymphedema is estimated about 140 to 150 million. Right? This is not only breast cancer related. So when you take the types of lymphedema, we have many types like primary and secondary. Categories to main two types: primary and secondary. Primary is like by bond. By birth itself, there will be malformation of the lymph nodes, or there will be no lymph nodes at all. So we divide those into like two phases, like before puberty, we will say, and post puberty. Like before puberty, we will call it as lymphedema tarda and lymphedema recurrenta. I will just clear and I will explain it what is it. Right. So what are the things we will be handling is a secondary lymphedema, right? So breast cancer related lymphedema is one of a secondary lymphedema. Then so any issues with the lymph nodes or within the lymphatic system will create lymphedema. What we are handling here is breast cancer related lymphedema, but we will be having elephantiasis, venous insufficiency related lymphedema due to any trauma and malignancies. Like these are the etiologies. In those etiologies, we will be handling only in this session we will be handling only the breast cancer related lymphedema. Right. India shares around 45 to 50% of the world's lymphedema. Total cases of lymphedema is like 140 and 150 and it goes on. In those 140 and 150 million, we are handling about 45 to 50% of it. But the cases that we are handling is not the breast cancer lymphedema alone. We are handling more of biliary lymphedema, right? And nowadays, the breast cancer related lymphedema is getting its peak, right? There. See, when we are doing an MRM surgery, the percentage of expected percentage of lymphedema is like 24 to 49%. In breast cancer conservative surgery, it is like 4 to 28%. In axillary lymph node dissection, it is 10 to 20%, and in sentinel lymph node biopsy, it is 5%. These are the chances that the patient will develop lymphedema. So, who's at the risk of breast cancer related lymphedema? So, the patient who is going for lumpectomy or a combination of lumpectomy with axillary lymph node dissection, or modified radical mastectomy, or combined breast cancer surgery with radiation therapy to the regional lymph nodes, radical mastectomy, sentinel lymph node biopsy, radiation therapy. Because as I told, radiation therapy it has a huge role, right? Like radiation every lymph nodes affect ஆகுனா இங்க நெருப்பு எரிய வச்சுட்டு பக்கத்துல ஒரு பாலித்தீன் கவர் வச்சு என்ன ஆகும்? Because of the heat wave, it will shrink. Okay, the same thing will happen in the VCR. Okay, so radiation பண்றப்ப because of the high radiation, the lymph nodes will get fibrosed. Because of the fibrosed lymph nodes, the transportation of the lymph will be affected. ஏன்னா lymph nodes already fibrosed, right? Fibrosed lymph nodes is nothing but it will not work, so it will become inactive. So inactive lymph nodes cannot transport material. So again the patient will develop lymphedema. That's why I told parasternal lymph nodes are also more important. Then breast cancer reconstructive surgeries like tram flap and percutaneous mastectomy. And in India we are not doing most kind of breast cancer reconstructive surgeries, right? We are directly jumping and we are going for MR, right? But in foreign countries and all, we will be they are doing more of reconstructive surgeries where they will be using an extender or a muscle flap or an implant, right? So these implant failures, reconstruction failures, those things will also intend to develop lymphedema. Yeah. So what are the stages of lymphedema? So there are 4 main stages. Latency stage. Latency stage is also called as stage of 0. Okay. Once the patient is have been undergone for axillary lymph node clearance or any kind of surgeries where their lymphatic nodes are touched or surgically repaired, right? So they are in a lifetime chance of getting lymphedema. Right? So the occurrence of lymphedema can start at a post-operative, like 3rd month of post-operative period, or 3rd year, or 8th year. It is irrespectively. Okay, but when the patient has been undergone for any axillary lymph node clearance or sentinel lymph node clearance, those patients are at a lifetime risk of developing lymphedema. They are called stage 0. And stage 1, 2, and 3. You can see the difference between these 2 arms. Like this arm has got surgery, but do you see any visible changes between these 2 arms? No, right? So it is called stage 0. This is stage 1. We will have some visible stage. Next, we will have more than 3 or 4 centimeter difference between 2 arm circumference. This is stage 4, where you will have more of skin changes, fibrosis, everything will happen. Like latency stage is transport capacity is reduced, no visible edema will be there, subjective complaint of heaviness will be there. Like the patients will tell, manual and imparting, there will be no difference in the arm. Okay, no edema will be present, but the patient will have some sort of shoulder heaviness or arm heaviness, right? The stage 1 is reversible lymphedema, right? The accumulation of proteinous edema is present, pitting will be present, and pitting will be soft, and the edema will be reduced in the elevation, right? Against gravity edema varum. When you elevate, when you rest, the edema will go. So that is called stage 1. Stage 2, again accumulation of protein will be present, pitting will become more progressive and difficult. See, we have stages of pitting also. So if you press பண்ணி பார்க்கறோம் அப்படினா pitting ல நிறைய stages இருக்கு. How fast it is going to refill. சரிங்களா? எவ்வளவு ஃபாஸ்டா refill ஆகுதுங்கறத பொறுத்து we are staging the pitting itself. I am not getting into it. But the pitting will be hard. It will become hard. Okay, so in first stage there will be pitting and it is soft. The refill will be fast. Here the refill will be slow and the pitting will be hard. Okay, refill slow or if the refill is slow, then what does it means? Means the long-standing edema is there. So the edema has been turned out more. So the fluid thickness has been increased. The viscosity of the fluid has been increased. Right. Then usually lymph we will term it as a high density fluid. சரிங்களா? Like honey type of texture. Honey மாதிரி high density lymph. So as long standingly it is present, it will develop the hardness of the fluid will become, right? And there will be some sort of fibrosis. So fibrosis starts to develop. That fibrosis is nothing but there will be the thickening of the skin. So because of the long-standing edema, the skin will become thick. The elasticity of the skin will become loose. So we will be finding it difficult to pick. Yeah? Yeah. What is third? Third one is called lymphostatic elephantiasis. There will be an accumulation of protein-rich fluid where fibrosis, sclerosis, skin changes, papillomas, hyperkeratosis, everything will be there. Like elephantiasis patient பார்த்திருக்கீங்களா? அவங்களுக்கு இருக்கிறதும் same lymphedema தான். Right? For them, it is because of the foreign worm. Those worms are blocking the inguinal lymph nodes. Because of that, the inguinal lymph nodes is getting failure and the edema is present in the lower limb. Then, அவங்களுக்கு என்ன ஆகுதுன்னா because as it is fully on against gravity position. எப்பவுமே பேஷண்ட்ஸ் நின்னுட்டே போறாங்க, கை ரெஸ்டே கொடுக்க போறது இல்ல, ஏன்னா கால்ல இருக்கு இல்லைங்களா? So because of that, there will be a faster skin changes. Then skin it changes like it will break and it will be fragile, and skin the papillum was small boils மாதிரி வரும் ஆல்ஃபுல்லா சரிங்களா? And at one stage the patients will develop lymphoria. Lymphoria is nothing but the patient's skin will lose its integrity and the lymph in the skin will break out and it will ooze out. Right? And the patient को நம்ம treat பண்ணலாம். We can reduce and we can reverse those conditions also. Right? Yeah. So, what is the diagnosis for lymphedema? So, diagnosis is generally done by the medical practitioner. Right? So, there are special ultrasounds, color Doppler ultrasounds, lymphoscintigraphy, CT, MRI, bioimpedance. Through these methods, we can able to diagnose whether the patient is having lymphedema or not. Right? So, the main thing what they will be doing is lymphoscintigraphy and bioimpedance. Bioimpedance where they will pass a current and they will calculate what is the extracellular fluid matrix, those kind of stuff they will have. In lymphoscintigraphy, they will inject a dye and they will trace it because the dye cannot be absorbed by the venules. As I told, larger than 4 carbon atoms cannot be absorbed by the venule of the capillaries. Then, so these dye which are larger than 4 carbon atoms, they will be absorbed by the lymphatic system. So those lymphatic system will carry the dye and they will take it towards the lymph node. Okay, அப்படி பண்றச்ச they will inject the dye and then they will take an MRI. Right? So that like contrast path நம்ம எடுப்போம் இல்லைங்களா CT ல same process. So அப்படி எடுக்கறச்ச we can trace. So lymphatic system ல எங்கெல்லாம் dye pass ஆகுது, எங்கெல்லாம் blockage இருக்கு. So by that time we can able to diagnose that the patient is having lymphedema or the patient is not having lymphedema. That. And assessment of lymphedema. So this is where we will play the role. Those things are done by the medical practitioners, right? So we will assess the swelling, assess the tissue change and skin, assess what is the severity and how the patient is having pain or anything. Yeah. So this is the globalized assessment pattern for lymphedema. That is called circumferential measurement. We will take an inch tape, we will mark like every 4 centimeter either in arm or leg. We will take a markation point, we will compare it with both the limbs. Then both the limbs we will compare. கடகடன்னு எழுதணும்னு அவசியம் கிடையாது. I have sent a study material. So they will be sharing. So everything is in there. So அதை நீங்க brush பண்ணிக்கோங்க. Now just listen. Try to take down the main points. Then so we will take the circumferential measurement and we will compare it with the other limb. சரிங்களா? So this is the globalized thing what we are doing. And this is a program called limb volume program. So நம்ம measure பண்ற program it will be in centimeters. We will say like armல வந்து 2 cm difference இருக்கு right and left. Like that we can able to identify. But how will you calculate in volume? So what is the volume? Volume of limb that is edema that is present. So we will put it in the software. This software will help us to calculate the centimeters into volume and it will show us a graph. It will show what is the difference between the right and left limb. Right? So this helps in calculating. This is water displacement method. This is the oldest method of assessing lymphedema. So where there will be a long beaker filled with water. We will ask the patient to submerge the arm or leg, and the water will overflow. We will measure the water and we will tell. So right side 500 ml overflow, left side 600 ml overflow. So 100 ml is the difference. Right? This is the oldest part, and it is a clumsy part because we have to change the water frequently. We cannot use the same water to the different patients, right? So nowadays we are not using this water displacement method. This is called pyrometer. This is the topmost method that is used in all over the world, but not in India, right? So in circumferential measurement, I told you, right, we will measure the limb girth. So ஒரு பாயிண்ட்ல வச்சு மெஷர் பண்ணுவோம், சரிங்களா? ஸோ இங்க இருந்து 4 cm நான் ஒரு பாயிண்ட் ஃபிக்ஸ் பண்றேன். இங்க இருந்து 4 cm. இங்க நான் ஒரு மெஷர்மென்ட் எடுக்கிறேன். So this is the measurement of day 1, right? The treatment path goes for a week, and the end of the week I am taking away the measurement. Same point I am going to keep, and I am going to take a 4 cm measurement. I can have a plus or minus 2 mm difference. Henceforth I will get a false value, right? So this can be avoided in pyrometer. Pyrometer is a device where we will just keep our arm. Our handle மாதிரி இருக்கும். You can see the handle there, right? You can see a handle here. The patient will just hold the handle, right? They will sit and they will hold the handle. A scanning laser will come in. It will convert our circumferential thing and it will convert into volume. So the chances of false values are 0.01. That, but the cost of the machine is high and it is not available in India. That Lymphostatic already I told you how you do that. See, here you can see they have injected the dye. The dye passes still here. It is not crossed over. So there is some issue within the lymphatic system. So here you can see this is normal limb, this is affected limb. Bilaterally they have injected the dye. Here the dye goes on towards the lymph nodes. Here it is not going because of the issue in the lymphatic system. So this is how the lymphostatic works. Right. So next is how we will assess the skin. We will look for dryness, pigmentation, fragility, redness, pallor, cyanosis, warmness, coolness, dermatitis, cellulitis, fungal infection, hyperkeratosis, dependent skin folds, and stemmer sign. Stemmer sign is a test, leave that apart. And other things are all the skin changes that we will look for the patient because the edema is present in the skin. A long-standing edema or a stagnant water will corrupt. A river will never get spoiled. The pond will get spoiled. So wherever there is a stagnation, there will be a development of microbes, other associated issues, and the place where it belongs to will eventually damage. So the place where it will eventually belongs is skin. So the edema is in the skin. So above the fascia, below the skin, right? So a long-standing edema will result in skin issues. So those kind of things we will be checked for. And the stemmer sign is nothing but we will try to raise the skin in the index finger, right? In the index finger, we will try to raise the skin. If we can able to pinch and raise it, there is no edema present because the edema usually starts in the distal part, not in the proximal part, right? Distal part. Our bustal point over namuke kaala edema, right? It is not coming on the upper areas. It will be on the distal part. So if you are able to raise it, there is no edema. Usually, a lymphedema patients we will be unable to raise it. Sarila, it is called stemmer sign, and this is called axillary vessel. Already Priyank has taken you how the lymphatic vessels and lymphatic channels will go. Sarila, when there is an injury to the lymphatic vessel, or when there is an discontinuation of the lymphatic vessel, then the lymph nodes are removed, or when the lymph vessels are fibrous because of radiation, right? The tendency of the lymphatic vessels will be lost. The properties of the lymphatic vessels will be lost, and there will become a shortness. So the lymphatics will become shortened. Okay, shortened like this, it will be like a cord-like structure, or cord like. So here radiation கொடுத்திருக்காங்க. The patient has been radiation here, right? The lymph nodes has been removed. The patient is given radiation. axillary lymph node clearance also be done. So, in a lymphatic vessels pass there will be discontinuation, and because of the fibrosis, this discontinued lymphatic vessels or non-functioning lymphatic vessels will become taut. Cord மாதிரி சிபி சைடுல இதெல்லாம் நீங்க அவங்களோட மசில் டெண்டான்ஸ் ரொம்ப டைட்டா இருக்கு பாத்துக்கிட்டீங்க. It will become like that, not that much of hard. ஒரு வெசல் எப்படி டைட்டா இருக்கும் அந்த அளவுக்கு டைட்டா இருக்கும். It will be like a string like that. Throughout the area it will be there. சரிங்களா? Not only here but also in the chest. As I told, இந்த quadrant ஃபுல்லாவே இங்க தான் drain ஆகுது. Right? So the entire quadrant is going to get drained here. Right? So if the patient is suffering from a lymphatic body, the patient will unable to lift the arm fully because it will have such a high pain. Right? The patient will have high pain. Because of that, the patient will not use his shoulder fully. So it is a secondary complication because of lymphedema. And if the patient is having lymphedema, again the clotting is going to hinder in their daily day-to-day life. சரிங்களா? ஏடியல் ஆக்டிவிட்டிஸ் எல்லாமே ஹிண்டர் பண்ண ஆரம்பிச்சோம். இதுக்கு மேலே எனக்கு தூக்கினா வலிக்குதுன்னா நம்ம அதுக்கு தூக்க மாட்டோம் இல்லைங்களா? Slowly they will develop adhesive capsulitis or PA, frozen shoulder. Every associated illness of the shoulder will be followed because of axillary lymph node. சரிங்களா? So we are there to release the axillary lymph node. Then you will tell in the later parts how you are going to release it. So now I have taken on what is breast cancer related lymphedema. Clear? Any doubts? We are out of time, so I am rushing fast.
So this is my disclosure. So as we already know about the lymphatic system, and there is any insult in the lymphatic system, so there is some disturbance or some edema which is known as lymphedema. There are many treatments in all over the world of lymphedema. As Gnanasekar told, there is some surgery, but it is too costly, and even after the surgery, there is failure. So the gold standard treatment of lymphedema is Cbt. So management, as he said that there is no cure of lymphedema. Once lymphedema is start, it will be whole life. We just able to manage to the near normal stage. So either medical, there are some drugs they are using like benzopyrons or diuretics, but nowadays due to that there is any kidney disease and fluid overload, so doctors prescribing the diuretics to drain the fluid. But still, this is really dangerous. If lymphedema patients start to take diuretics, means you are again developing the more harder lymphedema because the fluid part will drain. Okay, so the lymphedema became more hard. Surgical, there are some lymphovenous anastomosis, lymph node transfer surgery or deep vein surgery, but there is surgeries still in the process. There are many side effects and failure. So all over the world, the gold standard treatment is the CBT till now. So CBT is a complete decongestive therapy or complete physical therapy. This is a surgical management, lymphatic bypass procedure, where the surgeon is transferring the lymphatic vessels or connecting the lymphatic vessels to the unaffected to the unaffected area. There are some lymph node transfer during breast cancer. If right axillary lymph node is resected, then they can take some lymph node from the other part and they can put and just wait for further anastomosis. Some liposuction is there if there is thick or lymphedema. Liposuction is mostly common in lymphedema patients, and there is some debulking surgery. So the gold standard treatment is complete decongestive therapy or complete decongestive physical therapy, which having a 5 part. First is skin care, because there are chance of always infection in lymphedema patients, because the Gnanasekar told that the lymphedema is high in protein and high in fat, and there are cell debris, so this is the culture medium of the bacteria to grow. So if it is no skin proper hygiene, there is chance of infection. The infection which is common in lymphedema is cellulitis. So if lymphedema is not treated, no proper skin hygiene, cellulitis, again there is more lymphedema because cellulitis will take time to recover. Once cellulitis, there is more fluid coming to heal the cellulitis, again more lymphedema. So it's a vicious cycle. If not, no management of lymphedema. Manual lymphatic drainage, which is a special guided lymphatic drainage technique to the lymphatic vessels from the affected to the unaffected. Compression therapies depend on the stage of the lymphedema, also the phases of the treatment. There is two phases, like intensive phase when we are seeing first time the patient, and we need to reduce the lymphedema at the minimum stage. So it is known as intensive phase, and when lymphedema or lymphedema reaches to the plateau stage, when there is no decrease in the volume after your measurement, then it is maintenance phase. So both compression is different. And then yes, there is some decongestive exercises to increase the muscular pump, which ultimately increase the lymphangiomodrosity. And yes, the main important part is self-care because it's a lifelong disease. So patient or caretaker need to learn these all things: self-skin care, self-MLD, self-compression therapy, and self-exercise. The main important part is self-care. Okay. So management is intensive phase. I told you in the initial phase when we just assess the lymphedema. So it's depend on the staging or depend on the swelling or depend on the girth, how we are measuring in the intuitive measurement. And the maintenance phase when patient reaches to the criteria. So in the intensive phase and maintenance phase, yes, there is MLD done by the physiotherapist or the certified lymphedema therapist, compression, skin care, and exercise. In the maintenance phase, self MLD, self bandaging or garments. Sometimes we are using garments in initial phase. Skin care and exercise. What is missing here? I told you na? Self care. Okay. So these are the diagram. So this is intensive or decongestion phase, maintenance phase. So exercise is common in both. Skin care and bone care, if there is any bone in common in both. Here is the compression garb bandage. You will learn in your practical session. Here is the garment when swelling reaches to plateau. And here manual lymphatic drainage done by the therapist, here by the patient or caretaker. So MLD, we are not a massage therapist. So it is not a massage. Okay. So manual lymphatic drainage. So the gentle manual technique encourage fluid away from congested area, means affected area, by increased activity of normal lymphatics, which is still remaining, and bypassing ineffective or obliterate lymph vessels. So we are bypassing or rerouting. We will see in the demonstration how we will do bypassing from the affected to the unaffected. Okay. Finally, and it start from the proximal to the distal. Okay. So MLD. Ultimately, through the MLD, in my first lecture I told you now, we are indirectly increasing the lymphangiomodrosity. So what is the goal of the CBT? Treat lymphedema, yes. Treat or manage? Treat or manage? Reroute lymph flow because it's stuck due to mechanical damage or any insult in the lymphatic system. Increase lymphangiomodrosity. Suction effect because we are first decongested the unaffected, so it is able to drain from the affected to the unaffected. And reduce the lymph girth finally is our goal. Because if any female who will develop the lymphedema, They are unable to wear their ornament, they are unable to wear their normal clothes, and it is not socially acceptable for her to go with a 2 liter or 3 liter fluid in the arm in the society. Okay? Even the lymphedema, even breast cancer is common in male also, not in even only female. Okay? But the incidence is very less, but it is common. Till now I saw 10 to 15 male breast cancer cases. So it's not in only in female. It is common in male also. Not that much common, but there is incidence of male breast cancer. Effect of MLD, yes, increase lymph production because we are increasing the lymphangiomodrosity. Reverse of lymph flow means we are draining from affected to the unaffected, indirectly increasing the venous return, soothing effect, and analgesia. Because we are doing some soothing effect, so the analgesia. There are different schools of thought which they describe about the different types of MLT. There are most common is border or faulty. Here we will learn about the border. Okay, so there are different strokes in the lymphatic drainage in the different schools. There is Ludo, there is Catholic. So what are the principal? Skin is stretched. I told you na longitudinal lymphatic vessels. So we are doing the perpendicular. So there is two phase in the MLD. One is resting phase, one is the working phase. Most of the every phase is last till 1 second. So it should be gentle and slow, not fast, not too much pressure. When you will do the practical, you will be able to learn. So gentle pressure, central to proximal means we are going from here to here. First we break central, then proximal, then go to the distal. Healthy lymph nodes on the unaffected side, anterior and posterior trunk, and of course breathing exercise. Always we are starting the MLT with the breathing exercise to stimulate the breathing. Indirectly, it will help to increase the lymph circulation. Okay. Technique in the Voda technique. In the practical, I will demonstrate there are more main 4-stroke stationary circles, pump, rotary, and scoop. So this is the mechanism. Once you will do the proper MLD with the low pressure and proper rhythm, with proper working and resting phase, so the lymph will go from one lymphangium to the other lymphangium. Okay. See. I told you working phase, resting phase, stretch stimuli, anchoring filament. I explained when we do the skin stretch at that time, ankle filament will pull the endothelial cells. So there is gap in one lymphangium. So it will pull the lymph from the other lymphangium. So we will do the longitudinal stretch. You will see. You will feel. Directional pressure means if we always doing the perpendicular to the lymphatics. No high pressure needed. Damage anchoring filament lymphangium. If we will do the high pressure, it will damage the further lymphatics. So that's why in the lymphedema, there is lymphatic education or prevention education. No need to take blood pressure on that surgery hand. Yes, because in the blood pressure, it will go till 180 mm of H. Yes, it will further damage the superficial lymphatics. So we are avoiding to measure the blood pressure on the affected arm on the breast cancer patients. Okay. If you will do the high pressure, there is more chance of damage to the further tissue. So there is hyperemia, means increased temperature. Again, there is chance of swelling. Yes. In some cases, when lymphedema reaches to the more than second stage, which is known as the elephantiasis or fibrotic state, at that time we are using little bit more pressure, and there is peptidoglycosis. I will explain. So resting phase, lymph vessels absorb tissue fluid, interstitial space. This this is the working mechanism. Every area we need to treat 5 to 7 times, and both stationary or dynamic pattern. So I told you the anastomosis between the axillary, anterior axillary anastomosis. Behind there is posterior axillary axillary anastomosis. Means between two axilla there is anastomosis from the water side, either anterior or posterior. Okay? Anterior or posterior. There is one anastomosis from axilla to equina. Okay? When we will learn about the MLD, if this is the affected part, there is no lymph node or surgeon remove the lymph node. So either we will drain here or we will drain here. So we need to know about the anastomosis, okay, which is crossing the water sets. I told you there is less connection in between the water set, but there is connection which is helping us to reroute the lymph. This is the direction how we will proceed. It will be demonstrating in MLT sessions. So first is skin care. I told you need to care of the skin, little bit moist. Don't allow your skin to break. Okay, so maintain your skin hygiene. Use low pH cream if you want. Okay, avoid cuts if there is cuts. So proper clean with the betadine and all. If it is infected, go to the general practice. So then MLD I told you. Then compression therapy. So compression therapy depend on the stage, either multi-layer lymphatic bandage or garments. So multi-layer, based on the phase of the treatment, multi-layer lymphatic bandage, you will learn in practical session, high compression garment or combination of both, and bandage alternatives. I will explain about bandage alternative in further slides. So you will learn in the practical compression garment, combination of both, and bandage alternatives. So effect of compression, finally it reduces the filtration. Once you will compress, it will further reduce the lymphatic filtration. What is going on, which is responsible for lymphatic. Increase reabsorption from the interstitium to the lymph and from the lymphatic vessel towards the blood circulation. Prevent the reaccumulation of fluid because you already compressed the area, and improve efficiency of the joint and muscles when you will do the exercise. So there are different parts in bandaging. That's why we are saying multi-layer lymphatic bandage. We are using different types of bandage at the different area. There is one principle known as Laplace law. We are maintaining the conical shape. You will learn during your practical session how we will maintain the conical shape. Why it is we are saying multi-layer bandaging technique. In the lymphedema, mostly we are using a short stretch bandage. Normally, what we are using in the orthopedic condition, in ankle sprain or any edema due to orthopedic condition or post-surgical edema, we are using the non-strap bandage. Yes, this is strap bandage. But when you see the lymphedema bandage, it is short stretch bandage. So in short stretch, high working pressure. So that's why when we do the bandage, we will not say the patient to stop your activity. We will ask them to move yourself, to do exercise with the bandage. So if they will do the exercises, so the high working pressure, it will allow lymph to move further. In short stretch, high working pressure, opposite. In long stretch, low working pressure. That's why in the orthopedic, what we are saying, price. Yes, initial management, rest, short stretch bandage. So if it is not moved, the pressure is high. Low resting pressure. Here, high resting pressure. That's why we are saying patient to not to move during any sport injury, any orthopedic injury. We are applying bandage. So if it is resting, means resting pressure is high. So it will allow to decrease the edema. Opposite side, here we are asking to the patient to move, to do all activity. That's why high working pressure. So bandage will help to move more length. Here stretch from 30 to 60 degrees. Once you stretch the bandage, it will stretch only that much. But here, totally stretch. Just double. Okay. So these are the resting and working pressure. These are the bandage. These are muscle. How it is working. This is the difference between resting and working pressure. During the treatment, we are maintaining the conical shape from distal to proximal. Down, there is less girth. Toward the proximal area, there is more girth. So we are using some padding material. There are different type of padding material depending on the stage of lymphedema. Initially, we are using down to the low width bandage. When we go to the proximal, we are using high width bandage. So down either 4 or 6 centimeter, then 6, then 8, followed by 10. There are 12 centimeter bandage also available, which we are using in the lower limb lymphedema. Okay, so there is one Laplace law which is following this. So we need to maintain a conical shape. We need to do the low width at the distal, high width at the proximal, and these layers less should be opposite. At the distal we will use the high layer. At the proximal we will use the less number of layers. So these are the part of bandaging. So finger bandage, this finger bandage. You need to wrap up the finger, which is also known as molly-last or finger bandage. Tubular bandage, we are using a stockinette to the full arm or lower arm. This is the stockinette. You will see synthetic wool to wrap up or to maintain a conical shape. Dense forms depend on the state of fibrosis or depend on the fibrosis. There are different type of thin dense form, which is known as complex. There are different color and dense form, like white and orange, and thickness also is different. Inelastic short stick bandage, which is a different size, 4 centimeter, 6 centimeter, 8, 10, and 12. And adhesive tape to fix the bandage. Yes, and complex foam I told you. So finger bandage, short stick bandage, stockinette, padding foam, tape. Got it? So this is the finger bandage. First we apply the stockinette to the full arm, and after that we will start with the finger bandage. After that we will use the rose needle foam or padding pad, depending on the staging of the lymphedema, either normal foam or hard foam. Which hard foam, less thickness or more thickness, and after that we will use the bandage. 4 centimeter, 6 centimeter, 8 centimeter, 10 centimeter. Here more layer, less layer, less layer, less layer. So by this conical shape, number of the layer, width of the bandage, we are maintaining the pressure gradient. You no need to pull the bandage. You no need to do the bandage which you were doing in the orthopedic area. Like you are tying on the proximal area, then less pressure, in lymphedema nothing. This principle, like conical shape, width of the bandage less at the distal, width of bandage is high in the proximal, number of layers high at the distal, number of layers is less in the proximal, will ultimately create the pressure gradient. Any sketch? No? Any sketch? Everyone is able to see. So this is P sub-bandage pressure. I told you the resting and working pressure. So P as is directly proportional to the number of layers. So I told you we are maintaining a conical shape. Yes. Here we are doing 3 or 4 layers at the distal, followed by 2 layers, 1 layer. So if number of layer is high, pressure is high. This is Laplace law, physics, okay, or mathematics. So here, more layer, less layer, less layer. If number of layer is high, pressure is high. This is width of the bandage. So pressure is inversely proportional to the width of the bandage. That's why distal we are using 4 or 6 centimeter, 8 centimeter, and 10 centimeter. So its width is less, bandage width, pressure is high. Okay, got it? Understand? And the diameter of the limb. If diameter is less, pressure is high. Inversely proportional. So here, conical, here, the conical shape. I hope you understand. Or no? Yes or no? This is Laplace law. Little bit physics or math. Understand or no? If you will not understand this, you will not understand the multi-layer bandaging. So if you have any doubt, ask me. Because the treatment depends on your understanding. How you will create the conical shape, which bandage you need to take proximal, which bandage you need to take distal. So this is a normal scenario. Distal less, proximal high. In this, I told you the width, girth. If girth is less, pressure is high. If girth is high, pressure is low. So here girth is less, pressure is high. Here girth is more, pressure is less. Down we are using more layers. Then less layer, less layer. I put N on the above. If number is layer of high, pressure is high. So here we are using 4 or 3 layers. Here we are using 1 layer or 2 layers. So if number of layer of bandage is high, pressure is high. If number of layer of bandage is less, pressure is less. Then width of the bandage. Here distally we are using 4 or 6 centimeter, followed by 8 centimeter, followed by 10 centimeter. If the width of bandage is less, pressure is high. Opposite. Okay? Okay. Bandage alternative means not more, means available in India but abroad that we were using in Doha also. So some patient or their caretaker don't want to do bandage every day. It depends on them. You cannot force them. So they are asking if there is any alternative. So now in the market there are some different company like Rosidal, Juzo or Verison. They are making some bandage alternative, but it is not actual bandage. What we are achieving by the bandage, they will not achieve by the bandage alternative, but somehow you will manage. Like patient will say, I can come only 2 days, I cannot come 4 days. So in these 4 days, you can give the bandage alternative. So bandage alternative, like there is some reduction kit is available. It will depend on the your circumferential measurement. Then you need to discuss with this company. So they will make either by the custom made, they will take the measurement, or made by the make by according to the patient measurement, or there is some ready, either ready to wear or they need to measure and prepare. But there is no final solution of bandage. First and main thing is bandage. If not, then you can go for the bandage. Previously, they were saying that compression garment is only allowed in the morning, not in the night. But now there are some compression garment which having a less resting pressure. They have some research. They are saying that these compression garment you can use in the night also. Okay. Normally, when we start bandaging, we will say patient to wear 22 hours or 23 hours. When you will come next day, remove 1 or 2 hours before to just take their morning activity and we will apply again. If they are not able to tolerate, then Gnanasekar will explain. If they are feeling any numbness in the fingertips or increase in the pain or increase in the tightness, they can remove at any time. No need to fear. Okay, but bandage is applicable for 24 hours. Previously, the compression garment is applicable only in the morning, not in the night. Bandage morning and night. But now there are some compression garments that you can use in the night also because the pressure is less. Okay. So this is the replacement bandage in night. These are the bandage alternatives. Okay. So these are the different bandage alternatives. This is known as caresia or circuit. In this there are different marking is there. Like this you can see light mark. So you can wrap up the things. You need to cross and fix the velcro. So this is known as circuit or this is arrow wrap. So there are different companies who is making these garments. Either the patient can use in the night or they can use in spite of bandage if there is any issue. That no one can with the patient is alone. So how they will manage, or they are not able to learn maybe the radius breast cancer in the left and she has some issue on the right side like paralysis. You cannot do by the self-care and she is alone. So in this case either you need to call her every day, or if it is not manageable then you need to go with the bandage alternative which is known as circuit or arrow wrap or reduction. These are the some qualities of compression garment. It is like the texture should be good. So when you will choose the compression garment, always try to read about the compression qualities in garment company and ask the executive what are the qualities. And based on your study or your learning, you need to choose the garment. Okay, no need to like do the trust on the executive. What they are saying, we are just listening and we are using. No, use your brain. Okay, it should be intact. It's good for skin. The shape should be okay. Otherwise, like we will choose the compression garment. Patient will wear like 7 days. It will distorted. The elasticity is not good. So, what is the use? Patient already lost like 1,000 or 2,000 in upper limb compression garment, and again after 7 days you need next garment. So absent or minimal pitting edema you can use in that. Okay, swelling that can be contained by the compression garment, that in second stage or third stage you cannot use compression garment. So it should be palliative stage or early or preventive measure. Like there are some studies which is saying like if patient underwent axillary lymph node dissection, there is no lymphedema, but there is always latent fistings, which is not visible by the eyes. As Gnanasekar told, if any female, anyone underwent the axillary lymph node dissection or mastectomy, there is lymphedema, but it is not visible. Always they have some feeling of heaviness. Means because their lymphatic system is already compromised. They removed some lymph nodes, but there are some bypass between. I told anastomosis, it is maintaining. But when they will start more working and they will not follow your instruction to prevent the lymphedema, then what happens? They will do the more work, so the blood will come more, but it will not go because there is some damage. It will stay. Then it will change to 0 to stage 1. There is visible. Okay, so sometimes there is some prophylactic prevention, like if this patient want to travel abroad. Okay, so when they will take a flight, at that time air pressure is less inside the flight. Okay, because it's blowing at 25,000 feet. At that time internal pressure is okay, but outside pressure is less, so lymph will push. So there are some studies that saying that after long duration of flight, patient can develop lymphedema if they already have recepted lymph nodes. Even in flight, some people normally seeing that they've developed some swellings if there is long distance flight, like 10 hours, 12 hours. Same thing happened with the lymphedema. So in the prophylactic, if you know any patient, if they want to travel, use the garments. Give the garments so the pressure will maintain. Otherwise, once they will come back, start lymphedema. Okay? So these are the education you need to teach them. And ability to monitor skin changes, yes, the garment should be not too much tight. It should not make a wrinkles. It should be smooth and straight. These are the measurement. There are two types of garment, either ready to wear, which is small, extra small, medium, large, extra large, or XL, like our cloth. So these are the different size of garments available ready to wear in the market, different company, or sometimes you will not find that size according to your patient. So you need to call that executive of the company. They will come and they will take the measurement and they will make the garments according to the measurement. So there are different measurements according to the different company. Okay, it is not fixed. So normally the compression garment what we are using, so we need to check the pressure. So there are different standard, either British standard, French standard, or German standard. So class 1 garment having the pressure under the garment between 20 to 30 mm. Class 2 30 to 40. Class 3 40 to 50. Class 4 50 to 60. Okay. So normally in breast cancer related lymphedema and upper limb we are using class 2 garment. Sometimes you can use class 3. It depends on your assessment. For prevention, as I told you, if there is no lymphedema but already breast cancer and axillary lymph node is dissected, patient want to go abroad, at that time for the prevention you can give class 1. In lower limb, normally we are using class 3. If patient is okay to tolerate the pressure, you can go to class 2. So it all depends on your assessment of the lymphedema and patient demand, because your assessment is depend on your patient. And every patient is different. So once you will assess the patient, then you can decide your bandaging protocol, or after intensive phase, which garment you want to provide in the maintenance phase. It's not like that maintenance phase only garment. Like 6 days patient can wear 4 days garment and 2 days they can do the bandage. There is some devices which is, in my word, that you can save your time if you have like 6 patients in your clinic and one session of lymphedema management will take like 2 hours. Because once you will do the MLD, you will read out the sequence, it will take 30 to 40 minutes or 1 hour to the patient, depending on the lymphedema, like only one end or two end or 4 limbs. Okay, so minimum 30-45 minutes or 1 hour. Then bandaging another 30 minutes. So like if you have 6 patients, you have less time. So there are some machines available in the market. They are working intermittent, and there are many chambers. Previously there is, the pneumatic compression which we are using in ICU to prevent the DVT. So there are almost same machine, but they have different chambers. Okay, like 10 chamber, 12 chamber. So it will first decongest here, proximal. They saying that it is almost following the MLD sequence, but it is not replacement. Somehow you can manage your time, like same time 2 patients can put 1 patient on the compression pump for 1 hour or 30 minutes, put like 50 to 60 mmHg or 80 mmHg, and at that time you can manage other patients. Okay, so there are different type of machine and electrical air compression pump attached to a inflated plastic garment that is placed over the pressure advice 30 to 6, and usually normal treatment 30 minutes, 60 minutes, depend on you. If you have same time 3 patients, put 1 patient 1 hour, another patient 1.5 hours to maintain your clinic rotation. So IPCs provide to reduce edema with a decrease in capillary filtration. They are saying it's mimic the MLD, but it's not exact. What you will do by your hands, you cannot do by the machines. These are the some contraindications of even MLD or CDT or bandage, depend on area to area. cardiac edema. Many patients you will see they have some congestive heart failure. They develop edema. So you need to thorough do the assessment of the patient. It's not every edema is a lymphedema. It's our tendency when we attend any workshop, next 1 month we will see any edema in the lymphedema. It's not like that. If we will learn cupping, we will apply cupping to each and every patient. Either it is indicated or not indicated. If you attend a taping workshop, next 1 month or 2 months, every patient needs taping. Not like that. First assess the case. Do your thorough assessment. Because your assessment will decide your treatment. So take a proper time in the assessment, like 1 hour, 1.5 hours. Ask each and every question. Then your treatment is quick. It will take only quick time to deal with the patient. But do your assessment properly. Okay, so in cardiac edema, like congestive heart failure, acute infection, there is no MLT, no compression in any cellulitis. If you will see any redness in your breast cancer related upper limb, ask the patient, or if he or she develop chills, rigor, temperatures, ask the patient to visit general practitioner. Maybe they will start oral antibiotics or IV antibiotics. Once it will settle down, discuss with the general practitioner, take clearance from them. So okay, your antibiotics over, then apply low level pressure garment for the bandage. Okay, don't touch that affected part with the MLT. You can drain unaffected part first. Once everything is settled down, after 2 weeks or 3 weeks, start the MLT on the affected part. Acute renal failure. Many patients you will see that lower limb swelling. Okay, maybe their kidney is not working. Patient is already on diuretics. So be careful in your treatment. First, do your assessment. These are the contraindications, not absolute. It's on your clinical judgment. We were seeing many cases with congestive heart failure, renal failure, but not that much we are doing the bandage or that much pressure, but with their vitals, because there are some facility in our hospital that we can admit their patients, so we can check their vitals. Like every 2 to 3 hourly, we can check their outputs or input, and we can remove the bandage immediately. If not, then don't do it. Acute bronchitis, if there is any allergy, or there is any asthmatic patient, if they are not on bronchodilators, be careful. Because once you will drain, it will increase again bronchospasm. If it is they are on bronchodilators, be safe, take their symptoms and all, check after like 1 hour, 2 hours, tell them to sit in the clinic. If there is any issue, remove the bandage. And malignant lymphedema. Gnanasekar told that mostly lymphedema is started on the distal part, okay? But there are some cases where you will see the proximal lymphedema. But it is mostly metastasis. Means the female already have breast cancer before. They operated, everything is okay. But she suddenly develops swelling at the arm. Means there is warning sign, means there is metastasis again. There is recurrence of cancer. So at that time you will see the proximal lymphedema. But it is mostly with the cellulitis and infections. Complication of lymphedema is once there is no proper skin hygiene, once there is no proper skin care or no management of the lymphedema, you will see drastic skin. But once you will start their treatment, you will find a normal skin. So either hyperkeratosis, papillomas, or what, fungal infection, lymphatic cyst, lymphatic fistula, cellulitis, ulceration, malignant lymphedema, axillary vein syndrome, or angiosarcoma, means there is malignancy. So these are the types of skin infection you will see commonly in the lymphedema cases. I saw all. This is a lymphoria. The lymph is oozing. This is hyperkeratosis. This is cellulitis. See the color of the skin here, redness, patches. and this is the diploma C. Once you will start the treatment, they all will disappear. Maybe it will take 2 weeks, 3 weeks, or 4 weeks, but it will disappear. Any question?
Right? 1, 2, 3. I'm going on the side. சரியா லேட்டரல் போயிட்டு திருப்பி I am coming towards the index finger. பின்னாடி தாராளமா நின்னுக்கலாம், இடம் நிறைய இருக்கு. Right? Right? So இங்க இருந்து நான் திருப்பி medial side போக போறேன். Towards thumb. And I am going to wrap and going to come again behind the little finger. சரியா? So I am going to wrap the middle finger. விசிபிளா இருக்கா? ஏமா இவ்வளோ இடம் இருக்குமா, வாமா இங்க 2 பேர் உட்காரணும்னு அவசியம் இல்லைம்மா. தெரியலன்னா எழுந்து நின்றுக்கோ. பாக்ஸ் அங்கே வச்சிருக்கோம், பாக்ஸ் அங்கே வச்சிருக்கோம். சரியா? விசிபிளா தெரியலன்னா உட்காந்துக்கோங்க. சரியா? So I have finished first bandage. Right? First bandage முடிச்சிட்டேன். First bandageல thumb கவர் பண்ணியிருக்கேன், index finger, middle finger. 3 finger கவர் பண்ணியிருக்கேன். தெரியுதா? Movement of the flow will restrict. சரிங்களா? Lymphedema மெயினா இருக்க வேண்டியது என்னன்னா movement. The lymph should flow back. சரிங்களா? So we should apply a graded pressure. எங்கேயுமே இழுத்து இழுத்து we should not tie it off. Right? So initially நான் bandage எங்கன்னு ஸ்டார்ட் பண்ணேன்? எந்த பக்கத்துல ஸ்டார்ட் பண்ணேன்? இந்த இடம் பேர் என்ன? Styloid process. சரியா? இப்போ பேஸ் ஆஃப் தம்ப்ல இருந்து ஆரம்பிக்க போறேன். ஸோ ஃபர்ஸ்ட் ஃபிங்கர் டுவர்ட்ஸ் த styloid process. ஏன்னா இங்க ஆங்கர் பண்ணாதான் ரேப் கொண்டு வரச்ச தம்புக்கு கொண்டு வர முடியும். இங்க ஆங்கர் பண்ணி இப்படி கொண்டு வந்தா தான் தம்பு கவர் பண்ணும். இங்க ஆங்கர் பண்ணனும்னா it should go cross towards the little finger. Right? புரிஞ்சுதுங்களா? So I am turning the bandage. Right? From here I am going towards the little finger. Right? Again base of thumb கீழ போயிட்டேன். I am going towards the ring finger. நான் எங்கேயுமே I haven't pulled or stretched. I am just going with the stretchability of the bandage. சரியா? Right? And bandage பண்றப்ப யூசுவலா பேஷண்ட்ஸ் என்ன பண்ணுவாங்கன்னா எல்லாரும் தமிழ் தானே, ஹிந்தி, மலையாளம், தமிழ் புரியாதவங்க, anybody there? You never understand Tamil? Somehow, okay, like. So the patients will always help us out while doing the bandage by opening it fastly. நல்லா ஓப்பன் பண்ணுவாங்க. அப்போ என்ன ஆகும்னா இந்த பொசிஷனில் நீங்கள் பேண்டேஜ் பண்ணிட்டீங்கன்னா பேஷண்ட் லூஸாக விடுறச்ச நீங்கள் கட்டின பேண்டேஜ் எல்லாம் லூஸ் ஆகிடும். நெவர் ஆஸ்க் த பேஷண்ட் டு ஹெல்ப் யூ, நெவர் ஆஸ்க் த பேஷண்ட் டு ஃப்ளாங்க் ஃபுல்லி ஸ்ட்ரெச் பண்ணவே வேண்டாம். ஆஸ்க் தம் டு கீப் இட் சாஃப்ட். நீங்களே இண்டிவிஜுவல் டிஜிட்டாக ஓப்பன் பண்ணி பேண்டேஜ் பண்ணி சரியா? ஸோ I have covered all the fingers. I have left the nail alone. nail ஏன் left பண்ணிட்டோம்னா like when we fully bandage it, when we fully bandage the part, if there is any tourniquet happens in the arteries or veins, எங்கன்னா ஒரு இடத்துல நம்ம டைட் பண்ணிட்டோம் அப்படின்னா we can able to see the difference, or நம்ம tourniquet பண்ணிட்டோம், the vessel has been compromised அப்படின்றது சைனோசிஸ் வச்சு தான் கண்டுபிடிக்கலாம். nail தான் டிஸ்கவர் ஃபர்ஸ்ட் காட்டும், சரியா? so that we will leave the nail apart. Second thing, lymphatic channels are not present in nail and hair cuticle. முடியிலையும் நெயிலையும் lymphatic channels கிடையாது, ரைட்? இங்க எடிமா வரவே வராது. So fingers எல்லாமே கவர் பண்ணிட்டேன். I have covered all the fingers, right? I have excess of bandage. I am not going to tourniquet here. I am just going to spread it across. சரியா? I have just spread it across. Bandage கட்டினதுக்கு அப்புறம் இப்படி இருக்கணும். Your palm should be exposed. Only your fingers should be covered up, right?
I'm a surgeon who works in oncology, and I do palliative medicine. Palliative or end of life care. So I work in VS hospitals. Come for this meeting on physiotherapy, which is an international conference for physiotherapy students, and this is mainly for rehabilitative care for breast cancer patients.
With which the bandages will not touch your skin, as the lymphedema is there in the skin. The edema is there in the skin. More frequently, the patient will get skin issues. To prevent from that, the skin should be safely kept. Right? For that, we will never allow the bandage, short stretch bandage, to touch the skin. So we are using a stockinette layer. So this is the second layer. First layer is finger bandage, second layer is stockinette. Right? So it is just a cotton layer. சரிங்களா? ஸோ ப்ரொடெக்டிவ் லேயர். ஸோ தம்புக்காக நம்ம ஒரு சின்ன கேப் பண்ணிக்கலாம். ரைட்? ஓகேவா? ஸோ we have applied the second layer of stockinette. So third layer is the cotton padding. This is called cotton padding. Or we'll call it as cast padding while we are doing POP portfolio. The fractured patient we will be applying POP. For that we will be using the cast padding. Cast padding is nothing but this cotton layer, right? So we will be taking the cotton layer, and again we will start from the same side of stylet process. சரிங்களா? From here we will start to wrap. Bandage இப்படி பிடிக்க கூடாது. wrap பண்றப்ப இப்படி பிடிச்சிங்கன்னா unwind பண்றது கஷ்டமா இருக்கும். சரியா? Always the bandage should be held by this position, so that unwind பண்றது easy. சரிங்களா? Right. From here I'm going to tighten suthranappa. So I'm not tying it tightly. I am just going with this. சரிங்களா? From here I am crossing the thumb, getting inside. Again here 2 layer, 3rd layer. I am going around the thumb now to the wrist, and I am spreading it. Right? So spread பண்ணியாச்சு. So I will be using the second cotton layer. Practice to one cotton layer na. So I am taking the second cotton layer. Inga cover agaliyo. Endha area la cotton cover agaliyo. Anga irundha I am going to start it up. The area where the cotton is not covered and it is not layered, I am going to start it from that area. From this area. When I am coming to the cubital fossa, I am going to just do a figure of 8. Till this, I have been doing only spiral, right? Only in cubital fossa, I am going to do a figure of 8 because the patient has to flex his arm, right? And I am going to overlap with the spiral thing, and again I am going to just stretch it off. சரிங்களா? I am going to take the bandage till 2 centimeters or 3 centimeters below axilla. And the level where we are going to stretch the bandage up, right? So we have done the second layer. So third layer. First layer is finger bandage. Second layer is stockinette. Third layer is cotton bandage. Fourth layer is what we call it as a soft foam. Soft foam. This is nothing but a PU foam. Our sofa foam is same kind of foam with just of 2 mm thickness. Now I am going to use this foam and going to wrap him up. Same as we did, we start from the silent process. Right? And I am going to just cross over. Here no figure of 8, I am just crossing it over. That's it. Then which layer it is? Fourth layer. High resting period than working phase. Resting phase ಜಾಸ್ತಿ ಆகும், working phase ಕಮ್ಮಿ ಆகும். So that is the reason we are using short stretch bandage. Short stretch bandage have high working phase than resting phase. So even a simplest movement initiated on top of this bandage will help the lymph to flow back. Facilitate the lymph to flow. அதனால தான் இந்த bandage யூஸ் பண்ணுறோம். இதே long stretch bandage இருந்தால் we can stretch and it can stretch up to this area. Long stretch bandages stretch up to 300 times. Short stretch bandages stretch up to 30 to 50% of it. Right? And initially we will go with 6 cm, 8 cm and 10 cm. We will use 6 cm one bandage, 8 cm two bandages and 10 cm one bandages. If the patient arm is bulky, we will increase the 10 cm of second bandage. Right. If the patient arm is very thin, சரிங்களா, ஷார்ட்டாக இருக்காங்க, பட் ஆர்ம் பெருசாக இருக்குது, ஆல் ஷார்ட்டாக இருக்காங்க அப்படின்னா 6 cm இங்கே போட மாட்டோம், because the area here it will be less. So we will not use 6 cm, we will use 4 cm. இவருக்கு நம்ம 6 cm யூஸ் பண்ணுவோம், சரிங்களா? Done. So I am going to start again from the styloid. Right? I am just wrapping it off. சரிங்களா? From here I have to crisscross it between the thumb. So from here I am just going to make a fold, get it down, and again I am going to open it up. Then open it up, I am going to behind the thumb. உள்ள கொண்டு வந்தாச்சு, ஓபன் பண்ணியாச்சு, அந்த ஏரியா கிராஸ் பண்ணியாச்சு. Again I am going to come here because this white part should not be exposed, so that even pressure will be applied. Then, so while coming, first I pretty much say, yeah. So first I folded outward. Now I am going to fold inward, right? I am going to fold inward, right? Again I am going to turn towards the base, right? Then from here I am going to fold. I am going to take back, just flare it up. So you can see, right? I haven't stretched anywhere. எங்கேயுமே பேண்ட் இது ஸ்ட்ரெச் பண்ணி நான் டைப் பண்ணல. I just wrapped it, right? Right? Then shall I go on with the next bandage? 8C. 8. Right. Now I'll start with 8cm. Okay. So first bandage I'll start with thyroid. 8cm I'll come with the base of thumb. சரியா? So இங்க இருந்து நான் ஸ்டார்ட் பண்ண போறேன். 8cm. இங்க இருந்து just a gentle pressure, stretch, wrap. Okay. So இப்போ நான் wrap பண்றப்ப, so ஒரு பேண்டேஜ்க்கு மேல இன்னொரு பேண்டேஜ் wrap பண்றப்ப 50% ல wrap பண்றேன், right? So half of the bandage I am wrapping, right? Half of the bandage. So if I am going to wrap like this, it is 75%. If I am going to wrap like this, 100%. So if I am going to wrap like this, 25%. So according to the patient's condition, we can change the layering, whether we want 25%, 50 or 100 or 75, according to the patient's need. முக்கியமான விஷயம், எந்த பேஷண்ட் இவ்வளோ நேரம் கை தொங்க வச்சுருந்தா உட்காராது.